We're the only ones. Hey, Henry.
Hey, Tom, how you doing?
Not bad. How you been?
Good, how are you?
I'm pretty good. Good to see you. I think you just got muted.
Give me 1 sec.
Yeah. So it's just Columbia here. It's me and my 2 med students.
Oh, sorry. How you been? Oh, thanks for presenting, by the way.
Oh yeah, my pleasure. It's funny. It's just me and the 2 medical students from Columbia here.
Oh, yeah?
Yeah. What's up, Christian?
How much? How you guys doing?
Oh, not bad. Christian, this is Henry. He's he created this conference. And when I was a resident up at Connecticut Children's in Hartford, he was a fellow up there. So he stayed on as faculty. And he's the director of the point of care ultrasound program up there. Henry, this is Christian and Daniel.
Nice to meet you guys. Yeah, so usually they start showing up at 1:05 or something like that.
Yeah, sure. We'll wait for everyone to get started at 1:05. Looks like Cohen's is here.
Hey, Tom.
How you doing?
Good.
Hi.
Oh, is that Matthew?
Yeah, it's
me in the
Matthew.
background. I just spilled my lunch, so I have to clean it.
These things happen.
And hey, I'm Will, one of the fellows.
Oh, hey, Will, I'm Tom. Nice to meet you.
Nice to meet you, Tom.
We were
Yeah.
just talking about you, Tom, actually.
Oh, yeah, good things, I hope.
Will was asking me about if I knew anybody who had experiences at Westchester.
Oh, yeah, we can talk about that. It's a good place. It's high acuity. You see a lot if you work up there.
I'll probably give him your contact info, Tom, if you don't mind.
Yeah, sure.
How you doing? How things going?
Oh, life is good. Life is grand. I love it up in Tarrytown. Still have my beautiful view of the Hudson River.
You moved, right?
Mhm.
Did you move, or was that a while ago now?
That was a while ago. Yeah, so Henry, so the talk I'm giving today, I last presented in October, and since then I've had a few cool cases I'm going to talk about today. And I actually took them and I put them together. It's a talk that's about how to use point of care ultrasound to evaluate patients coming into the ED for respiratory complaints. And so it's a series of cases of that. But 2 of the cases I already presented to you guys back in October. The one was that CSF pleural effusion case, and the other one was a bacterial pneumonia. So I took those out and I just put in 2 other cases that I had recently, which aren't respiratory, but they have cool sonographic findings. And so that way it mixes it up a little bit. It's not just the same thing the entire time.
Oh, no, that's fine. So that's fine. Always looking for respiratory. I think that's one of the things I want to scan more of. So then, and then we had Aaron present last week as well about some pneumonia findings. Tom texted me. He just lost power. I don't know if everyone's aware that New York is having some issues with the power the last couple of days. So hopefully it comes back.
Hey, Adam, Dr. Sivitz, I didn't realize it was you there. How's it going?
Right, what's up? Is that your guys' conference room?
This is our office,
Our
Or
office.
closet?
our literal, yeah, our closet.
The
Exactly.
closest thing we have.
Very good for social distancing in here.
Has some romantic lighting.
Wait, is that because the closet didn't actually have a light in it, so you had to put up the string lighting?
Yeah, pretty
Like
much.
office. It's all right. Windows are overrated.
Ed Adam, so I forgot to, I was gonna email you telling you that I missed the meeting, but that's because I'm in Maine right now, so I couldn't make it to the meeting. So hopefully you can send a summary of what happened so I can just jump back on.
Yeah, the summary email is on my to-do list for today. I'll see if I can make it through there. But yeah, I mean, it's, and to give you credit, like the whole idea of trying to do a scrotal ultrasound study team really came from these meetings with everybody talking about different cases that they had and different stuff going on at their institutions. It seemed like the right time to try to pull everybody together and just say, like, what's the world doing and can we do anything prospectively to look at it?
Yeah, I agree. I mean, I was I've been meaning to tell Rosemary because Stephanie Cohen actually saw Rosemary's talk, and then after that, like, essentially she detours towards testicle, and just like Rosemary did. So I feel that, yeah, I think it's a great idea. So
Yeah.
glad you're starting it up.
And I mean, as for POCUS stuff, it seems ridiculous. Like, we use FAST as kind of like our gateway drug for getting people in there, but like clinically, torsion is something that's so time sensitive that, like, I don't know why we haven't been doing it more often or why there isn't more focus on it.
I agree. Yeah, I mean, as I send you my in one of the email thread, is like we're spoiled because they literally go from the waiting room into the radiology seat. So, but there are sometimes, especially overnight, where I have used it, where I just call the urologist and was like, "Hey, there is my images," and they look at it, I was like, "Yep, that's torch. I'll be right in." But that just happens overnight because there's no. They have to come in for when we order overnight ultrasounds for the scrotum.
Yeah.
But otherwise, they just get flagged in the waiting room and they go straight to the radiology suite.
Hey guys, I'm back. Sorry about that. It's pouring where I live, and I just lost power for a minute. So hopefully that doesn't happen again. Are you able to see my screen?
Yeah, Tom. Yeah, and no
Okay.
worry. My brother warned me because I'm here in Maine with my brother, and he told me that there was going to be some outages in New York. So I was
All right.
anticipating something. But anyways, yeah. But everyone, thank you for joining this week. We have Tom Kennedy today presenting back. So he had exciting cases back in October. So we're looking forward to this talk. And Tom, whenever you're ready, you can take it away.
Yeah, sure. So for those of you who don't know me, I'm Tom Kennedy. I'm one of the ultrasound faculty at Columbia in New York City. And like Henry said, I presented back in October, and I've had a few cases since then, which I included in here. The first 4 cases are patients who presented to the emergency room with respiratory complaints. And it's just to illustrate how point of care ultrasound can help with such patients. And then the last couple, I just varied it up and put in some different pathology. And so this first case that we have is, you guys can see the screen, right?
Yep.
Okay, so this is a 9-month-old male, and he doesn't have any significant past medical history. And he came in as a transfer from an outside hospital emergency department. He had presented there because of a cough that he had for 3 weeks. And when he was there, the physicians noticed that he was intermittently tachypnic. And because of that, they ended up getting a chest x-ray on him. And the chest x-ray I'll show you in a minute, but it was abnormal. And it prompted an electrocardiogram, an EKG. And the EKG was also abnormal, which then prompted an echocardiogram. And the echocardiogram diagnosed a heart condition for which he was transferred to us. And I'll tell you what that diagnosis was at the end. But when he came to us, there was something on the chest x-ray that still wasn't explained. And I'll show you that next. But when he got to us, his vital signs are shown there. They were all okay, except he was mildly tachypnic at 47 breaths per minute. But his pulse ox was fine, 100%. And when you looked at this kid, he was awake, alert, looking around the room. He didn't look like he was in any distress. whenever you go near him, he would cry incessantly. And so it was hard to examine him and hard to scan him. But his cardiac exam was normal S1, S2. None of us could hear a murmur, but cardiology said they heard a 1 out of 6 murmur. And he didn't have any gallop or friction run. His extremities were well perfused. His respiratory effort was normal, but he did have decreased aeration in the left-sided lung fields. He didn't have any rales, and his abdomen was soft. It was non-distended. He didn't have any hepatomegaly. Right here, this is his chest X-ray. And so you can see he has complete opacification of the left hemithorax. If you look at the trachea, you can see it's shifted to the right. And radiology, they interpreted this as most likely a large pleural effusion due to causing the opacification. And they also interpreted this as mild cardiomegaly. And his labs that he had, his CBC was unremarkable. His BMP was within normal limits. So was his hepatic function panel. But the significant findings were his troponin and his BNP, which you can see here were 106 and 22,000. So we grabbed the point of care ultrasound, we grabbed the ultrasound machine. We started off looking at his heart, and this is the subxiphoid view. And so if we take a still image of this, you can see the right ventricle is here, and it's super small. It's compressed by this gigantic left ventricle. And they read cardiology read the echocardiogram as the left ventricle pancaking the right ventricle. I thought that was a cool description. And here's his right atrium, his left atrium. You can see a small pericardial effusion anteriorly and also posteriorly. And then looking at his IVC, remember he was fighting me the whole time. This is his IVC here. We're looking at the IVC in its long axis. And it's hard to keep you see it opening into the right atrium, but it's hard to keep your probe on the cylindrical structure and long axis while the kid's pushing you and fighting you. So you see, it's hard to get an accurate interpretation of it, but it doesn't look plethoric at all. It looks like it's probably collapsing actually. And when you have this trouble looking at it in long axis, you know, you can always rotate it to transverse. And so here we're looking at the IVC in transverse orientation. You have the IVC here and the aorta here. And looking at it here, it's a little bit easier to assess how much the IVC is collapsing. And you can see the walls are pretty much coming together and touching. And this was somewhat surprising because when we looked at his heart in the parasternal long view, which is shown here, here you have his right ventricle, his left atrium, his massively dilated left ventricle, his aortic outflow tract, and then this is the anterior leaflet of the mitral valve. There's the descending aorta. It's very small. He's a baby. Here you can see that pleural effusion posteriorly, and you can see a little bit anteriorly. But if you look at the function here, you look at the global contractility of that left ventricle, it's barely squeezing at all. And then you look at the mitral valve as an indirect assessment of left ventricular ejection fraction, and you can see it's barely opening. It's really very pathetic. And it was surprising that this kid who has such poor left ventricular function didn't have a plethoric IVC. His IVC was collapsing, didn't have hepatomegaly. When you listen to him, didn't have rales. If you look at the heart and its short axis shown here, these are the papillary muscles. You can see the pleural effusion anteriorly and also laterally. And when you look at the function, same thing. It's just another angle to assess the function of this left ventricle. And it's barely squeezing. The chamber size is barely changing at all. And it's so dilated, you can't even see the right ventricle. Here we're looking at the heart in its apical 4-chamber view. Right ventricle, right atrium, left ventricle, left atrium. And we don't usually use this view to assess contractility, but you can get a sense of it in every view. And you see again, the left ventricle, the mitral valve is barely opening. We often use this view to compare the chamber size, and it doesn't, the left ventricle is clearly much larger than the right. So now we have an answer for why he has this cardiomegaly, but we still don't have an answer for why he had complete opacification of the left hemithorax. And so remember, the left side's the abnormal side. We started off looking at his right side, and here we're longitudinal axis, and we're in the posterior lung fields, and we're starting superiorly and sliding the probe inferiorly. And what you're seeing here, you see the ribs with the shadow posterior to them, and in between the ribs, you can see the pleura. And as we go from superior to inferior, what you're seeing is normal lung. So as we come down, the A lines become a bit clearer. And in this kid who has a horrible left ventricular ejection fraction, we don't see any B lines, no evidence of pulmonary edema. So despite his poor function, no hepatomegaly, no plethoric IVC, no B lines, still doing okay somehow. And now we look at the left side. The left side was the side that was completely opacified on chest X-ray, and we see this. So this is on the left posterior lung field, starting superiorly and sliding the probe inferiorly in the longitudinal axis. And if we take a still image of this when we get to the base of the lung, right here, what you're seeing is, we'll start from the right side of the screen and work our way to the left. You can see the diaphragm here. You can see a small pleural effusion here. Remember, radiology interpreted as the X-ray as most likely being a large pleural effusion causing the opacification, but ultrasound helped us figure out that wasn't the case. In between the ribs, you see all this atelectatic lung. And because the lung is compressed and all the air is out of it, it acts as an acoustic window that allows us to see the heart anterior to it. And then adjacent to the heart, you see this pericardial effusion. So I thought this was a pretty cool picture. When you play this is everything in real time. So you see that collapsed lung, the small pleural effusion, the dilated cardiomyopathy, and the pericardial effusion. And again, this is starting from superior and going inferior on that left side, the left posterior lung field. You can see it's the entire lung that's collapsed. So now we have an answer for why he has his opacification of left hemithorax. It's because of severe atelectasis. And so this kid, he came to us with the diagnosis of Alcapa. So he had the anomalous left coronary artery from the pulmonary artery. And that's what caused his dilated cardiomyopathy over time. And his Alcapa was successfully repaired, but the problem with him is he was in the hospital for a while because of the respiratory compromise he was having. They had a hard time weaning him off positive pressure. And pulmonology was consulted, and they decided to get a CAT scan of the chest. And what the CAT scan showed was he had this segmental obstruction of the left main bronchus. And I thought this was really fascinating. They decided to go and do a bronchoscopy on him. And so I got the video of the bronchoscopy. And looking at this video, we start off at the level of the bifurcation of the left main bronchus. So the bifurcation of the left main bronchus. And then they pull the scope out. And as they're coming out, you see the left main bronchus, and then you see the carina. And the right side of the screen is anterior. You're going to hear someone in the video get excited and say the right side is posterior. That's not the case. The right side is anterior, and the left side is posterior. So the heart's anterior to, the heart's on the right side. And so now I'm going to play the video. And so what you're seeing is this dilated cardiomyopathy, this pulsatile compression of the left main bronchus. So the dilated heart is completely compressing the bronchus. And that's why that kid had a collapsed left lung. It's because the heart was so dilated, it was causing compression of the left main bronchus. Eventually, over time, as they treated his heart failure, his respiratory compromise began to improve. He was discharged home. And when he followed up as an outpatient a week later, the only concern the mom had was that the kid was constipated, which is pretty good. But the downside is when they did the echocardiogram, his left ventricular ejection fraction was only 11%. It's amazing this kid's doing as well as he is with such a poorly functioning left ventricle. And I don't know how he's going to do long term, but I thought that was such a fascinating case. I've never heard of a dilated cardiomyopathy completely compressing a bronchus before. So I thought it was really neat. Have any of you guys ever seen anything like this? No? All right, cool.
Never.
What's that, Adam?
No, never.
Yeah, I thought it was pretty wild.
And we get to see lots of dilated cardiomyopathies, but not to that extent.
Yeah, I thought that bronchoscopy video was awesome. All right, any questions about that?
So what's the reason? They don't know the reason, basically, like most things. They don't know why.
Why it compressed the bronchus?
Why he had cardiomyopathy.
Oh, no, he had it from his Alcapa. So,
Oh, sorry, I missed that.
Oh, yeah, it's okay. So there was a slide. So he was diagnosed with anomalous left coronary artery from the pulmonary artery. And so that's what caused his dilated cardiomyopathy.
So Tom, did you get a chance to try to get one of those high short axis views to look at the aortic valve and see the absence of the left coming off?
I don't know how to do that. Maybe one day, but not on this kid. All right, moving on to the next one. So case 2, so this is more of a basic one, but it's one of the most helpful things that I think point of care ultrasound can help you with. So this was a 9-year-old male with asthma who came in. He presented with shortness of breath that started the morning of presentation and increased work of breathing severely that started 2 hours before coming in. And he didn't have any associated symptoms, maybe a little bit of nasal congestion, but that was it. His vital signs are shown. He's tachycardic at 137. He's normotensive, tachypneic, 38 breaths per minute, and hypoxic at 90%. And he came in about a half an hour before I got there. And when he was first seen, the physical exam findings by the initial physician are written here. He was tripoding, retracting, nasal flaring. He had poor aeration throughout, severely decreased, but they documented that they could hear wheezes at the bilateral bases. They treated him like a severe status asthmaticus. They gave him back-to-back Duonebs. They put an IV in, gave him magnesium, normal saline bolus, methylpred. He was so bad, they even gave him IM epi. And then they signed him out to me. And so I go in to see him, and his exam hadn't really changed much. He was on continuous albuterol by the time I went in there. And when I listened to him, he was definitely diminished with breath sounds bilaterally, but worse so on the right. On the left, you could hear a little bit of wheeze, but on the right, you couldn't hear anything. And really, he sounded hollow on the right. And so I suspected that he may have had a pneumothorax. And the team before me had ordered a chest x-ray, but chest x-ray always takes forever to get there. And it's nice to have some confirmation that you're dealing with a pneumothorax before you stick a needle in a kid's chest. And because if you're wrong, you're going to cause the pneumothorax. And so I grabbed the ultrasound machine, I put it on him. And this is his left side. So remember, the right side is where I thought there was probably Henry, can you mute your microphone? And on the left side, so what we're seeing, you look at the pleura, which is immediately beneath the ribs, and you can see it's moving. You see lung sliding. And then in addition, you're seeing these coalescing B lines, these vertical hyperechoic lines coming from the pleura. They obliterate A lines, they move with the pleura. There's a sign of interstitial edema. And in this kid who is having an asthma exacerbation, we hear wheezing. This is probably evidence of a viral respiratory tract infection causing interstitial edema, probably what was triggering his asthma exacerbation. And as we come down, you're seeing the heart as well, since we're anterior on the left side. Then you look over at the right side, and you see everything moving because the kid's in respiratory failure and he's pan-retracting. So you see the chest wall moving. But when you actually look at the pleura, right below the ribs, you don't see any movement at all. It's completely stagnant. And this is his anterior lung field. And then just to get a sense of how big this was, we looked laterally with the ultrasound probe, and same thing, you don't see any lung sliding. And so by this point, I felt confident to stick a needle in him. I went outside to get the needle, and by that time, chest X-ray had gotten there. I should have just put the needle in, but I let them take the chest X-ray. I guess it made me feel even more comfortable. And this is his chest X-ray here, and you can see it's this giant pneumothorax that was causing obstructive attention pneumothorax. And so we put the needle in, it decompressed him, followed that with a pigtail catheter. And then he ended up getting a CAT scan while he was inpatient. And they saw this large pulmonary bullae that he had, which was the source of the problem. And they did a thoracoscopic resection of that. And so a couple things with this case, chest X-ray can take forever to get to you to help you out. And like I said, it's helpful to have some sort of visual confirmation, at least in my opinion, to know for sure that I'm dealing with pneumothorax. And being able to grab the ultrasound and figure it out in 30 seconds, it's super helpful. And the other thing with this case is I realized that in kids that are in such respiratory distress like this, you can't actually use M mode. They're moving so much, you try to use M mode and the graph is just getting all distorted. But that's it. So this was a basic case, but one of the most useful things that you can do with point of care ultrasound, I think. Any questions about that case? All right, going on to the next one. Yep.
Oh, can I ask you a quick question?
Yeah, definitely.
Sure. This is Stephanie Cohen from Emory. Not so much related to the, first of all, great case, great use of POCUS. Not so much related to the ultrasound, but I'm just curious, when you put in pigtails, do you usually provide sedation? Or, I mean, obviously this child was in severe respiratory distress, wasn't really a candidate for sedation, but just curious what y'all do for that.
Usually give them fentanyl. I don't sedate them, fentanyl and then just local anesthesia. And they usually he did great. I had Child Life come in and walk him through it. Yeah. All right, going on to the next case.
And a lot of tape to hold down the arm.
Yeah. So this case is pretty cool. This is, this isn't the case that I was thinking of, but this is also a great case. So this is a 13-year-old obese female, and she came in with 1 month of intermittent left-sided chest pain that had gradually been worsening. And she had 3 days of shortness of breath. And then several hours before presentation, she developed a severe respiratory distress, increased work of breathing. And her vital signs are shown there. You can see she's tachycardic at 135, tachypnic at 36 breaths per minute. And she's in respiratory failure. She's hypoxic at 85%. On exam, she looked very anxious, ill-appearing. She was sitting upright and pan retracting. You listened to her heart, and she was tachycardic, but there was no murmurs, no rubs. And her extremities were warm and well perfused. She didn't have any extremity edema. And respiratory, she was tachypnic, but she had clear breath sounds throughout. So it seemed unlikely that it was going to be a pneumothorax like the last patient. So again, grab the ultrasound right away and put the probe down and looked at her. So we didn't look posteriorly on her, but she was in so much distress. We just looked in the anterior lung fields and the lateral lung fields. And the left anterior lung field looked completely normal. And the whole left side looked normal, anterior and lateral. On the right side, the right lateral looked normal, but the right anterior is shown here. And this was the only place we saw abnormal lung findings. So when you're scanning the right anterior lung field, this is showing the superior and inferior halves. The inferior half, that corresponds with the right middle lobe. And so superiorly, it looks normal. But as you come down, you see this rib space inferiorly is completely filled up with coalescing B-lines. Liechtenstein has that blue protocol, the bedside lung ultrasound for emergencies. And it has a really nice flow diagram that helps you figure out what etiology of respiratory distress you're dealing with. And this pattern is considered the AB profile. So A is normal, you see A lines, and that's what she had on the left side. And B is B lines, which we see here on the right side, so focal B lines. And that pathway suggests that if you have unilateral B lines in a respiratory distress patient, that there's a good chance it's going to be pneumonia. This could be edema from the periphery of a consolidation that you're just not seeing. Hasn't reached the pleura yet. And so we saw this when we did lung ultrasound, but then we moved on to the heart. And when we looked at the heart, this is the subxiphoid view. I was worried I was going to see a pericardial effusion, but she didn't have one, so no fluid that you can see here. I tried to look for her IVC, but I couldn't find it. So she was upright when I came in the room. I did this scan with her at about 45 degrees in the bed. Whenever I would try to lay her flat, she would get worse. Her chest pain would get worse. She felt like she couldn't breathe, and she would just pop right back up. So I was doing this at a 45-degree angle, but no matter what I did, I couldn't find her IVC. And that actually becomes relevant later on. We'll come up with that again. It's kind of interesting. So after looking subxiphoid, we looked at the parasternal long view, and we saw this. And when you look at her, so looking at her left ventricle here, it looks like the function is adequate. It looks like it's contracting well. The mitral valve is opening nicely. When you look at that right ventricle, though, it looks way more bulbous than what we normally see. Normally it's more of a triangular shape, it's low pressure, but this looks spherical and like it's ready to pop. And I moved the probe more towards the base of the heart. So this is still the parasternal long view, but I went more towards the base, and I saw this, which I hadn't seen before. I thought this was pretty neat. If you take a still image of this, so there's these two asterisks here, and the anterior asterisk, the one on the top, when I first saw that, I questioned, like, is that fluid? Is that a pericardial effusion? But the shape isn't right, and the location isn't right either. And then, as I'll show you in the next image, you can see that the right ventricle is really very dilated, which is why it looks so bulbous in this parasternal long view. And so I thought that this was probably the right atrium, which is what it is. It's dilated right atrium that you're seeing in the parasternal long view. But that asterisk in the bottom, I thought maybe that was the dilated right atrium, like wrapping around. I wasn't sure what it was. I sent this to two cardiologists, and what they both taught me is that that's actually the right pulmonary artery that you can see back there. And this patient ends up getting a CAT scan that showed that both her pulmonary arteries were severely dilated. And so that's what you're seeing here, which I thought was pretty cool. This is her parasternal short view. And you can see that right ventricle on top, anteriorly, is really very dilated. It doesn't have that croissant shape like it should. And the left ventricle, the right ventricle is so dilated that it's pushing the interventricular septum into the left ventricular chamber. And so that left ventricle, instead of being a nice donut shape, instead of being circular, it takes on this D form. And so this is the D sign. It's just the D is on its side. And so this is a sign of right heart strain, increased right-sided heart pressures. And if you look here, this is that same image on the left showing the D sign. And you can just compare this to a different, you can compare this to a different patient where you see how the left ventricle should be shaped, more of a circle. So I thought this was a nice example of the D sign. I then tried to look at her apical forechamber, but because she couldn't lay supine and she was in respiratory distress, it was hard to get good images. You can catch glimpses here of the right ventricle and the left ventricle. And I know it's not catching it at the right angle, but it's really not that impressive. Like, it's not, you can't tell that the right ventricle is that dilated here. There's that one article that's published in Academic Emergency Medicine that talks about how comparing ventricular size, chamber size, it may be more reliable to do it in the parasternal short view, which I think this case, illustrates. But classically, we usually do this in the apical forechamber view. So with those findings, with her chest pain, with her hypoxia, her respiratory distress, pulmonary embolism became the first thing on the differential in this 13-year-old female without any medical history. And so we ordered her within 10 minutes of her hitting the door. We knew this was a PE, which is really cool. It shows how ultrasound can be used to rapidly narrow the differential diagnosis and expedite diagnosis and management. And so we ordered a CAT scan for her, but she was really obese and the nurses couldn't get an IV in. And so we used ultrasound to place a peripheral IV. This is just showing the vein in the center of the screen, that anechoic circle. And at the end of the clip, you can see bubbles going through it. That's us flushing the IV and confirming proper placement. And so she went on and she got this CAT scan done. And it showed that she had acute pulmonary embolisms in both of her main pulmonary arteries, and they were extending to every lobe of her lungs. And in addition, she also had these wedge-shaped pulmonary infarcts in the right middle lobe and the left lower lobes. And I wonder if those B-lines that we were seeing in the anterior inferior lung field, that corresponds with the right middle lobe location, those B-lines may have been because of the pulmonary infarct that she had, which is kind of cool. On CAT scan, you could also see signs of right heart strain. You could see the septal flattening of the interventricular septum, and you could see the right atrial enlargement. And then in addition, she had abdominal heterotaxy with polysplenia and an interrupted IVC with azygous continuation, which I didn't even know that was a thing. But that's why I couldn't find her IVC, because she doesn't have one. She ended up getting admitted. And so when she was with me, she was classified as a submassive PE because she had evidence of right heart strain, but she was still normotensive. Within 2 hours, we got her up to the ICU, which was great. And then within a few hours of her being in the PICU, she transitioned to a massive PE and started to decompensate. She became hypotensive. They had to put her on epinephrine and dobutamine infusions. Her respiratory distress worsened. She ended up on BiPAP with inhaled nitric oxide. And ultimately, a few hours after that, they ended up having to intubate her and bring her for placement of these ecosonic catheters. And these things are really cool for those of you who aren't familiar with them. Here's a chest x-ray, and it's showing them. And so they get placed and they go directly into the pulmonary arteries. And they infuse TPA right into the clot. But what's really neat about them is that they emit ultrasound. And the ultrasound hits the clot and helps to break up the clot so that the TPA can get into it better. And hopefully have a better outcome. So ultrasound saved this girl 3 times. It expedited the diagnosis and the management. It allowed us to place a peripheral IV that was big enough to get a CAT scan. And then it even broke up her clot. So this is proof that ultrasound is awesome. She ended up having a negative hematologic evaluation. And so it's not clear why why this 13-year-old female had a massive pulmonary embolism. Someone brought up her abnormal anatomy, the fact that she has an interrupted IVC. I don't know if that's a risk factor, but either way, she ended up doing okay. And that's it. That's her case. Any questions about that one? All right, going on to the next one. So I don't know if you noticed, but this is an age progression. So we started with infants and now we're up to 21-year-olds. So this is a 21-year-old female with a history of meningitis back in 2017. And she came in with 1 day of pleuritic chest pain, as well as shortness of breath with exertion. And additionally, over the past month, she's been developing these skin nodules. 3 months ago, she had COVID-19. And her vital signs, they're shown here. They're only significant for tachycardia. So her heart rate was 124 beats per minute. And on exam, she looked like she was uncomfortable. She was tachycardic, but otherwise had normal heart sounds. Tachypnic, but had normal breath sounds. And dermatologic exam revealed that she had these 2-centimeter subcutaneous nodules that were non-tender and had no overlying skin changes on the left arm, the right leg, and the left chest wall. So we grabbed the ultrasound machine. And here we're in the subxiphoid view. And you can see she has this circumferential pericardial effusion. Here we're looking at the IVC and its long axis. And with respiration, it's the diameter of it is changing, it's changing less than 25%. And so it's, it's pretty plump. And here we're looking at the parasternal long view. And again, you can see the pericardial effusion anteriorly and posteriorly. When you look at the left ventricle, the contractility looks adequate. That mitral valve is opening well. But when you look at the right ventricle, the anterior wall of the right ventricle is doing something unusual. You can see it kind of collapsing inward. It is collapsing inward. And some people describe this as like a trampoline effect. It almost looks like someone's jumping on a trampoline. That's the way that the anterior wall of the right ventricle is moving. And you can see this is an early sign, this anterior wall collapse. It's during diastole. It's an early sign of tamponade physiology. This is a comparison. At the left is the image that we just saw. The right is an image of a patient who also has a pericardial effusion, but doesn't have this abnormal movement of the anterior wall of the right ventricle. So here's the anterior wall on this patient. Here's the anterior wall on the other patient. You look at that left picture, again, you see that trampoline effect. You look on the right side, you don't see that. So the left side is early tamponade physiology, the right side is not. One of the things you can do is, when the heart's beating this quick, she's beating at 125 beats per minute, it can be hard to tell when that anterior wall of the right ventricle is collapsing, whether it's during systole or during diastole. And so you can put M mode on to help you figure that out. And remember, M mode is this graph shown on the bottom. The y-axis is the depth and the x-axis is time. And when you look at this line here is the right ventricular anterior wall. This here is the interventricular septum. And this line corresponds to the movements of the anterior mitral valve leaflet. And so when you look at that right ventricular anterior wall line on the M mode, when it moves, when it collapses is when it's going downward, when it's moving away from the probe. And you can correlate that with the phase of the mitral valve. And so you can see every time the right ventricular wall is collapsing, it corresponds with the mitral valve being open. So it's occurring during diastole, which is pathologic. If you look here in the parasternal short view, you can get a sense of how big this effusion is. You see the heart just floating in the circumferential effusion. And then here's the apical four-chamber view, same thing, just another view of the effusion. We got her laboratory results after the point-of-care ultrasound was done, and her white count was up a little bit, 13. She was a little bit anemic at 10.4, and her platelets were mildly elevated, 470. All her inflammatory markers, her CRP or ESR, were both elevated, 62 and 75. Her troponin was negative, less than 6. Her BNP was also within normal limits, but right at the limit. 240 is the upper limit of normal. And her urinalysis, this urinalysis only had 5 squamous epithelial cells, but you can see it was positive for nitrites, small leukestrase, white blood cells, red blood cells, and bacteria in these hyaline casts. She ended up getting admitted, and her follow-up urine culture was negative. And she got brought to the cath lab relatively quickly, and they did a pericardiocentesis, and they drained 375 mLs of bloody fluid. The cell count is shown here, so 17,000 white blood cells, 345 red blood cells. The studies for bacterial and fungal infections were negative. They did, I believe they did flow cytometry on the fluid. It was negative for any neoplastic process. And she ended up doing well and getting discharged. And after she was discharged, some more of her laboratory studies came back, and they were positive for p-ENCA, so p-ENCA, those antibodies, and also the myeloperoxidase antibody. And while she was still admitted, she had persistent microscopic hematuria. And so they had her follow up with nephrology as an outpatient. And with nephrology, a week or so later, the microscopic hematuria persisted. And so they decided to go ahead and do a renal biopsy. And these were the interpretations of the biopsy findings. So she had this focal necrotizing and crescentic glomerulonephritis, pauci-immune. She ended up following up with rheumatology, and they're diagnosing this as her pericardial effusion was an atypical presentation of an ANCA vasculitis, which I thought, is pretty cool. That was her. You guys have any questions about her? All right.
What were the skin findings supposed?
Oh, they were just these nodules. They were hard nodules without any overlying skin findings. And they biopsied those too. I forget what the interpretation of the biopsy was, but rheumatology said that it fit into this ANCA vasculitis process.
Interesting. So it was within the skin, wasn't it?
When you're writing it up?
Yeah. All right, moving on. So those are the respiratory cases. These next ones are just to switch it up a little bit. So this one here, these last two I had in the past couple months. This was a 21-year-old female. She had a history of PCOS, and she came in with constant abdominal pain that had started the night before. And it had started periumbilically and then migrated to the right lower quadrant and also to the right flank. And it was associated with nausea, but no other symptoms. Her vital signs are shown there. They were normal. And on exam, the only significant thing on exam is that she had right lower quadrant pain with palpation. She didn't have any CVA tenderness. She had laboratory studies done, which are shown here. Her CBC was fine. Her electrolytes were fine. Her renal function was fine. But her urinalysis had 6 white blood cells and 10 red blood cells with trace leukosterase. I saw this patient initially when I was on a scanning shift. And so I was scanning with some of the medical students. And when we went in, these were the pictures we got. So remember, her pain's right lower quadrant. This is showing the left kidney in its long axis. And when you're looking at the left kidney, we don't see any hydronephrosis. We don't see any calculi. It looks normal to me. And then we go over and looked at the right side. You can see she had this moderate hydronephrosis. See that the pelvis and the calyces are dilated. To help you distinguish between vasculature and hydronephrosis, you can always put color on if you're not sure. You can see this is urine, it's not blood. So she had this moderate right-sided hydronephrosis. And then we took a look down at her bladder, and this is showing the bladder in its transverse orientation. And we're fanning back and forth over this hyperechoic stone that we see. We see the stone right here, and it's stuck at the ureterovesicular junction. And one of the things you can do to help figure out, is this really a stone that I'm looking at, is you can always put color on it. And the rough surface of the stone, when you put color on it, generates this twinkle artifact. So it looks like this beautiful, colorful comet comes right off the stone. And so these findings were all consistent with, with urolithiasis causing her pain. You can also help figure out if this is a complete obstruction or partial obstruction that's causing the hydronephrosis by putting color on and looking for ureteral jets. And she had beautiful ureteral jets. And one of the cool things with her, and I've seen this on a few patients, and I don't know why this happens. Hopefully you guys can tell me, but every once in a while, I'll have a patient where I don't even need color. You can just see the ureteral jets shooting out. Do you guys know why that is? Most of the time you need color to see it. I don't know either, but it's pretty cool. So this is a cool picture in B mode, and you can see those ureteral jets shooting right out. So I told the attending.
Can you go back to the twinkle where just have people who want to see it again?
Yeah. Yeah, this one's kind of cool. Hold on. This is going on and off. All right, going on.
Awesome, thank you.
Okay. This is my favorite. I love this. So anyway, so I told the attending who was taking care of this patient that she has a stone, and that I was completely sure. And then they do the radiology ultrasound, and this is the interpretation. In the findings, I just took out a quote from the right kidney. So it says the right kidney is normal in contour, size, necrogenicity, measures 10.9 centimeters, and they only said there's mild pelviectasis. And they were so unimpressed by it that they didn't even include it in the impression, which is all that most people usually read when they get radiology reports. So, this was a complete abdominal ultrasound study. They said non-visualization of the appendix, which of course doesn't exclude appendicitis. And there was a small quantity of free fluid in the pelvis, but they didn't even comment on the hydro or on the presence of a stone. Now, her pain persisted. And because of her persistent pain and the fact that I told them that I saw a stone there, they decided to go ahead and get a CAT scan. And the CAT scan findings came back right when I came on shift later that night. And what was interesting is that the stone that I saw, which was down at the UVJ, the ureterovesicular junction, it wasn't there anymore. And instead, she had this other stone up here, this proximal stone. And she went to the bathroom, but she didn't mention anything about passing a stone. And so, she had two stones, which is kind of interesting, or she had one stone that learned how to climb. I don't know which it is, but I'm joking. But she had two stones. Thought that was kind of neat. Any questions about that one? All right, so we're going on to the last two cases, which I actually combined into one. So this is a 27-day-old male, and he comes in with 1 week of non-bloody, non-bilious vomiting. It's projectile at times. It's associated with weight loss and also decreased urine output. His vital signs are shown. He was tachycardic at 177 beats per minute. And his weight, that 2.93 kilograms, when you graph this on the weight for age growth chart, it's way, way below the first percentile. So he's really small, not gaining weight well at all. And on exam, despite that, he looked great. He was active, happy. He wasn't in any distress. His cardiac exam was normal. He had good perfusion to his extremities, good capillary refill time. And his abdomen was non-distended. There was no masses, non-tender. We were concerned this might be pyloric stenosis, hypertrophic pyloric stenosis. And so we went ahead and quickly did a scan. So we're using the linear probe here, and we have it transverse in the subxiphoid position. And you can see here, this is hypertrophic pyloric stenosis. So if you look at the right side of the screen, you can see the stomach with all this contents within the stomach, none of which are passing through the canal, through the pyloric canal. And on the left, that anechoic circle, that's the beginning of the fluid-filled duodenum. And so we don't see any contents passing through. So functionally, this is consistent with hypertrophic pyloric stenosis. And if you take a still image, like I said, that's the stomach. There's the pylorus there. The measurements, you remember the measurements for hypertrophic pyloric stenosis, you remember them by remembering pi. So pi for pyloric stenosis. And pi, the width of the muscle should be less than 3 millimeters. And the length of the canal should be less than 14 millimeters. So when you measure the width here, and remember the width is the outer hypoechoic layer. The muscle is the outer hypoechoic layer. And so this is the way to measure it. You can see the measurement there is shown in the bottom right. It's 3.5 millimeters. So it's above 3 millimeters. So the width is consistent with the diagnosis. And then looking at the length of the canal, the measurement shown in the bottom right is 14.9 millimeters. So, objectively, the measurements fit, greater than 3 and greater than 14. And then functionally, the findings fit. Nothing's passing through the canal. And what was awesome is for some reason, I went over a year without being in the emergency room the same time as a baby presenting with hypertrophic pyloric stenosis. So I never got to do these scans. It was kind of annoying. And this night, I had 2 patients present at the same time, both with hypertrophic pyloric stenosis. So I literally went from this room to the next room and scanned them both, and both were positive. And this next one, the next patient is shown here. The orientation here is a little bit different. So you're seeing the stomach in the center of the screen. You can see all the contents of the stomach floating around in there. And then the pylorus is going posterior to the stomach, kind of wrapping back towards the duodenum. And if we take a still image of this, what you're seeing is this here. This is the hypertrophied muscle that's bulging into the antrum of the stomach because it's hypertrophied. And one of the pathognomonic signs of hypertrophic pyloric stenosis is what's called the cervix sign. And what happens is you have the muscle on both sides of the pyloric canal bulging into the antrum, and it looks like a cervix bulging into the antrum of the stomach. As the disease process progresses, the hypertrophied muscle starts to push the luminal surface and the mucosa out into the antrum. And when that pushes out, you usually get one little bulge from the center of the pyloric canal, and it creates what we refer to as the antral nipple sign. You know, you have the muscle on both sides and then the lumen sticking out in the middle. But this is the first time that I've seen this. This disease was so progressed that you had both luminal surfaces sticking out. And I hadn't seen this before. I thought it was pretty neat. And if you look at this, you know, the muscle here that I have highlighted in white looks like a body. This looks like a face and a head. And these look like ears. And this looks like a lot like a bunny to me. So I think we should call this the antral bunny sign. And if you look at the video again, it's perfect. So another pathognomonic sign of pyloric stenosis is the antral bunny sign. That's it. That's all I got. You guys have any questions about anything or any comments?
Those are great, Tom. Really
Thanks.
good cases.
Thank you so much.
A bunch that I feel like we could read in a journal. There's some unique ones.
Have you guys seen that, the both lumens sticking out before? I haven't scanned many pylorises that were abnormal. So maybe that's a common thing to see, but I hadn't seen it before. Adam, I know you've scanned a ton.
Can't say that I've ever seen the bunny sign, so
Excellent.
it's all yours.
Oh man, this is a great day. All right, well, thank you all for listening. And Henry, thanks for having me come and talk again. I really appreciate it. All right, guys, have a good day. Yeah, take care.
Bye.
All right, thank you, Tom.
Nice to meet you.
Do you want to do your
Excellent.